So let's all put our mobile phones aside and stand by to welcome our next speaker. She is Sergeant Andrea Wong, the Paramedic Specialist of the Singapore Civil Defence Force, and today she'll be covering the topic on pre-hospital management and drowning incidences. Ladies and gentlemen, let's give her a big round of applause.
Good morning, distinguished guests, lifeguards, trainers, fellow speakers, and everyone. Thank you so much for having me here. It's both a privilege and a pleasure to just be able to share more about what it's like and what we do on the front line. So just a bit about me. My name is Andrea. I've been in the force for about 4 years now. So today I'm just going to share a bit more about how we manage drowning incidences in a pre-hospital setting. So just what we're going to go through today, just a bit of demographic of the cases that 995 actually receives in the year 2023, between the months of January to November. Just definition of drowning, a brief pathophysiology so you understand what it is that we sort of have to look out for on the ground. Some complications that can follow drowning, some factors that actually affect the clinical outcome of a patient who has been through a drowning incident, the response and management that SCDF actually undertakes when they go for such calls, the challenges that we face on the ground, and then 2 case studies just to sort of apply everything that I've talked about today, and just some things that people can do just before SCDF arrives, and also some tips to ensure safety during water activities. So in 2023, just between Jan and November, a total of about 30 cases out of 200,000 calls that we've received, and it ranged from pediatric to elderly, so really anyone can be a victim of drowning. Majority of them were accidents, some of them were suicide attempts, but majority of them were accidents, and majority of them actually were conscious patients that presented with complications rather than patients who were completely unconscious or already in a state of cardiac arrest. And this is usually the case because either lifeguards or passerbys have already started some kind of intervention. And then the second most outcome following that is that the patients are already in a cardiac arrest. So much like what Mr. Ng had gone through, so drowning is a process where that results in the primary respiratory impairment from the submersion of in a liquid and also inhalation of that liquid. So whether they survive or not, they have been in a drowning accident. I think a common mindset that we have when people hear about drowning is that the person already died, which is not always the case. So the patient that we encounter can be both conscious or unconscious. And just briefly, the progression of how drowning occurs, usually something goes wrong in the water. It could be something as simple as a cramp. It could be something more serious like a seizure. And then that starts to cause some stress and panic to the person who is swimming. And then as a result of that, they start to aspirate some of the water, swallow some of the water. And they either try to hold their breath, or they actually go into this involuntary breath hold, which I'll go through more later on. And then eventually, because of the lack of oxygen you're taking in, your brain starts to receive too little. Your heart also starts to not effectively pump blood to the body that needs it. And eventually you're going to a state of cardiac arrest. Okay, so I did mention something about involuntary breath hold. So if you've known like drowning victims, a lot of them end up vomiting a lot. That's because they tend to swallow a lot of water when they panic. A part of that reflex that your body does to prevent water from going into your lungs is that it goes through a laryngospasm. So if you see the larynx, it's basically just your vocal cords. It tends to close up so that it protects the rest of your airway from water, from letting water go in. So it's good because it protects you, but it's so bad because you really just are essentially unable to breathe anymore, even if you wanted to. That's why it's involuntary. So going deeper into the lungs, usually typically it only kind of opens up when there's a lot of carbon dioxide building up in your body, and then it tells your brain, okay, it's time to breathe. So going deeper into the lungs, there's a few things that can get affected by the water entering your airway if it actually eventually does. So if you look at your lungs, there are these little, if you see like the little cauliflower head thing, that's your alveoli. So it is coated with a layer of what we call pulmonary surfactant. It's critical and is necessary for gas exchange to take place. So your oxygen, your carbon dioxide. And when water actually goes in, it starts to wash out this surfactant. So you got a diffusion problem now because the gases are not exchanging effectively. And then on top of that, sometimes your water also has contaminants. So these can actually irritate your bronchial lining. So your bronchial, trachea, yeah, all these can start to get irritated. You start to constrict, so it gets a lot tighter. So similar to your asthma patients, there's the kind of thing that they can experience. Yeah. And then, so I was talking about the surfactant. Once that actually washes out your alveoli, actually can start to collapse. So it loses its structure. And because if you see the alveoli, you see a lot of blue, you see a lot of red coating. Those are all blood vessels that actually coat the alveoli. So imagine this is your alveoli and your blood vessels coating it. Once the alveoli loses its structure, you see that the surface is now no longer in good contact. So the alveolar capillary interface, yeah, it can actually result in inflammation. It causes some dilation of the capillaries itself, and then you get a lot of leakage of plasma into your alveoli. So when that actually happens, you start to get the thing, the foaming that Chancellor was also talking about just now. Yeah, okay, so that's what can happen in the lungs. And then moving on to the heart, because you're no longer breathing effectively, a lot of your lactic acid can build up. This can actually go into this thing called metabolic acidosis, and that can actually disrupt the rhythm of the heart. So your heart pumps at a certain rhythm. Once that's disrupted, then your heart doesn't actually pump as effectively as it should. And if you need blood to go to everywhere and that pump is not working, you naturally are just not getting enough of what you need, which is oxygen and some other nutrients. And so you see this triangle. It's just critical systems all failing one by one, and it will continue to fail all the way until eventually your brain also doesn't get enough oxygen. There's not enough signal to tell your body to work the way it should. And so eventually you come to a point where the signal to breathe also stops and the patient goes into a cardiac arrest. Yeah. Okay, so some of the complications that we have to consider on the front line. This matters because we have to know what a patient has gone through so that we know how to make sure they have the highest chance of making it to the hospital and receiving proper treatment. So one of the common ones is hypothermia, which basically if your central body temperature is below 35 degrees, you could be in a state of hypothermia. Just now I mentioned that water can enter your lungs, and that can actually lead to pneumonia or even just chest infections. So even if you know someone who has been through a drowning and they are not unconscious or they're still alive, they're still talking to you, these are actually complications that can be occurring at the same time. So it's very important that they actually receive medical attention. Yeah, and then I mentioned about the surfactant being washed off, and then you can actually get pulmonary edema. So this can actually start developing even 24 hours after your drowning incident. So it's not just, I go home and I'm fine. I could actually not be fine, yeah. So that's why it's very important to actually see a medical, get medical attention for that, to make sure that there's not actually anything else going on. There could be spinal injury, depending on how the patient actually ended up in a drowning incident. Were they in a diving accident? Did they have a seizure? They could have hit their head at the side of the pool. Any of these little incidences, they could have slipped. Yeah. And eventually, after the brain has gone through a period of time without oxygen, usually that's about 4 to 6 minutes, brain damage can really start to settle in. So some factors that also affect clinical outcome, these we need to consider because these are questions that we need to ask as part of the patient history. These will be good to hand over to the hospital as well, so they know what to expect, what kind of symptoms that the patients might exhibit later on and things that they can treat. Yeah. So the duration of submersion matters. This will also determine how far the hypothermia has gone. It will also determine the duration and the severity of hypoxia if you know how long the patient has been in a drowning incident. Were they struggling with water for 5 minutes, 1 minute, 30 seconds? That all makes a difference. Were they unconscious for a long period of time? How long was it before a lifeguard actually came or SCDF actually arrived and intervened? The location determines the cleanliness of the water, which is not so significant for us as first responders, but more important for secondary complications. So I mentioned about the contaminants entering your lungs, the things like that it can affect later on. So if you can actually tell the hospital, this patient was at the canal or at the beach or in a pool, these waters are all very different, they all contain very different particles inside. The age of the victim matters because usually younger patients have a better chance of survival. So what we usually do when we get a call, we will first have to evaluate the scene. Things like drowning incidences happen at large bodies of water, which are in itself a source of danger to us. So only trained personnel try to intervene. Usually we are not the ones who will jump into the water. Yeah. We also have to ensure that the area we work in is dry because of the amount of equipment we're handling. If AED is required, these things have to be, the area has to be dry for these things to work. And we also need to ensure that our crew is safe so that we can render assistance to the patient. So we have to also make sure we're a safe distance from the water body itself to prevent any further casualties. So when we actually approach the patient, we'll check for their level of consciousness. If they are responsive, then we know that they're alive, which is a good thing. If they're not really responsive, then we have to check their pulse. Yeah. So if there is no pulse, that's when your BCLS, your ACLS interventions will begin. But in the case that there is actually, the patient is conscious, we can actually start to rule out things for like the spinal injury. We can actually ask them like, what happened, do you remember? So if we can clear the spinal injury fast, that's good. That's the first thing that we'll clear. If the patient is unconscious, then we have to think of how and we can actually consider spinal in this case. So was there any alcohol consumption involved, for example? If they were at a party and everyone was going a bit, rah-rah, then it could have been an accident. If it's a fall, so the mechanism of injury is important. Was it fall, was it diving? And at the end of the day, if there's no reliable witness or history that someone can give, the safest way is always to take a precaution. So we would do what we call a head grip. So you see the guy over there. So you just hold the head in place, make sure that there's no unnecessary movement of the cervical spine and the rest of his body. We also have to ensure that all wet clothes are removed, so that we can place pads if it's necessary. This is also to limit the amount of water exposure to the patient, which will make his hypothermia worse. So if a patient is conscious and talking, we know the airway is patent. But in the case that a patient is unconscious, we'll actually take certain measures to keep it patent. So on the left, this side, is what we call an OPA. It's called oral pharyngeal airway. So what it does is it just holds back the tongue of the patient. So it's called oral pharyngeal because it ends at your oral pharyngeal, which is basically the back of your throat. If the patient is actually in a cardiac arrest, we go to a more advanced airway management, which is called the laryngeal mask airway. So it's called the LMA, which is the one over on the further this side. Yeah. So this one actually sits further down. It sits right above the larynx, and it connects to a BVM, so you can actually deliver oxygen more efficiently. Yeah. Besides that, you also want to make sure, if you can, that the patient has managed to vomit out any water that he swallowed. If there's any foreign body, you want to try and get that out as well. Okay. Then next, we want to make sure that the patient is well ventilated. So oxygen is actually one of the most important treatments needed by a drowning victim. Chancellor mentioned about the NRM. So that's actually the non-rebreather mask. How that works is, if you see this mask over there, and here, okay. So you see this like white circle here. These are actually valves on the mask. So what happens is oxygen will come through here, into this bag, fill up this bag, and then the patient breathes it in, right? The valves actually prevent oxygen from leaving the mask, so they would be receiving 100% O2 in that sense. Yeah, and if patient is in cardiac arrest, then we would use the BVM similar to what Chancellor showed as well. One important thing to do is we have to auscultate the patient using the stethoscope. So what you would typically hear if a patient has inhaled a lot of water is this thing called crackles. So just imagine taking a straw, blowing into your cup, you hear the bubbling sound. That's essentially what you would hear when you actually auscultate the lungs. We also want to support their circulation as much as we can. If their blood pressure is too low, we would have to send IV and try to bring their blood pressure up. In the case of a cardiac arrest, we would also give them drugs like adrenaline. It's a pre-diluted, this one? It's a pre-diluted pen, injection, sorry, yeah. We will also give them amiodarone if we had any shocks given to the patient. So these are things that help to get that rhythm going again for the heart, and also to stabilize the rhythm if it's too erratic. The next thing we want to do is also ensure the patient exposure to the water is limited as much as we can. So patients should be dried. We have blankets in the ambulance. We would basically do anything we can to try and keep them warm, try and keep them dry. So blankets, these blankets are actually pediatric blankets. So they're actually for newborn babies, but they're thermal wraps. So whatever we can use, we use basically. And we have this in the ambulance, so why not? So if it helps to keep the patient warm, we can always just use it as well. Things like just turning the aircon down or just turning it off. Anything that really helps the patient, we would try to do. We would also take some relevant vitals, so things like his blood pressure, his hypo count. Might not seem like it's important, but like I mentioned, if there's no relevant history, you don't know what happened to the patient, why they would suddenly go into a drowning, it could be maybe even just the blood sugar was too low or something like that. So we have to also take these vitals to see what else we can rectify for the patient, what else we can treat. So at the end of the day, our job as frontliners, the most important part is we want to make sure the patient has the highest chance of survival in order so that they can reach the hospital and get definitive treatment. If the patient is in cardiac arrest and there is no spinal injury, we will also use the mechanical compression. So these two, they call the dumpers. So they actually do the chest compressions for us. This is good because it provides a very steady, regular chest compression. It also helps to free up our men so that we can focus on treating other parts of the patient as well. So there's just two different variations of it. This is what we call the call pulse, and this is called the Lucas. It's just different stations use different machines. So in the event that a patient has spinal injury, we'll then take the spinal precautions. So you see these equipment on the left, on your right. So this is actually called the ergon, or we call it the scoop. How this works is, you see this top part here, and this bottom part here. There are two notches that basically fix your spinal cord together, so they can be released. And so when it's released, basically your spinal cord can be opened up like that. Yeah. So it's two halves of the spinal cord. And why we call it scoop is because you can actually scoop the patient up like that. So it minimizes a lot of movement, which is good for any spinal precaution you want to take. And then of course we'll put on the C-collar on the patient, and as well as the head immobilizer, just the orange thing. Yeah. So this will help to transport a patient out with preventing any more or any kind of further spinal damage that may happen. And then of course you monitor the vitals en route all the way until they reach the hospital. So some potential challenges we face. As first responders, we go to wherever we are called to, and most of the time that means the environment is totally out of our control. So it can be things like, if it's a large water body, that's a source of danger to us. If it's at a canal, lighting is always a problem. Even when we go for cases, let's say, I'm in Clementi Fire Station, so I've gone for cases at West Coast Park itself. Lighting also not great. So things like that, you would have to bring a torch, that kind of thing. It's not always ideal for us. The torch is big, it's heavy, and you have to manage the patient. Yeah. Crowd could always be a hazard. Usually when things like that happen, there's a lot of people tend to arrive at the scene. Yeah. It can be helpful, it can also be disruptive. Other hazards that can be present, if there's alcohol involved, there'll be glass bottles, things that are more dangerous to us. The mix of keen that is on scene is also can be challenging because their family member is the one that is the patient right now, so you can expect that there will be some distress, some emotional distress, yeah. And on top of managing the patient, we also have to manage the NOK to make sure that they're stable. The last thing we want is to have another patient. There have been instances where the NOK actually faint on scene, and we have to tend to now 2 patients. Yeah. So as much as we can, we want to keep them calm. Lack of reliable eyewitness history is always an issue, not just in drowning, but especially in drowning cases. It's very. A lot of times they go swimming alone, or like nobody even saw them in the pool, nobody saw them, what happened. They leave them just for 5 seconds, and next thing you know, they're already floating. So this is always a common occurrence for drowning cases. Alright, so I'll just go through 2 case studies that we've been through. First off, the 55-year-old male. So the patient was swimming alone in a condo pool, and he actually had a seizure in the middle of the pool. So the lifeguard saw him struggling, jumped inside the pool and pulled him out. And because the patient looked like he was choking on a lot of water, the lifeguard actually did some chest compressions. And after a few cycles, the patient actually vomited the contents out. So when the EMS arrived, the patient was already conscious, good thing. And they actually found out that he has a known history of epilepsy. So when the paramedic auscultated the lungs, they found crackles in all lung fields, meaning the entire lung was just bubbly. O2 saturation was at 84%. You ideally want this to be above 95, so this is quite low already. So he gave him a high flow of oxygen with the NRM, with 50 liters of oxygen. The paramedic in this case took spinal precaution because of the history of the seizure and also the fact that no one really saw what happened, so it was safer to take spinal precaution for this case. Yeah. So they transported to the nearest hospital, which in this case was Ng Phong, and they made a standby call to the medical team to receive the patient. So some challenges that they faced was the lack of reliable history. We're not sure how long the patient was seizing for. We're not sure how far he was from the walls when he was seized. So we don't know what his injuries he might have sustained. We can see visible ones, but let's say if there's any internal injuries, we wouldn't know. One challenge was, this is always a challenge, how to actually do spinal precaution in a swimming pool. Because it's not possible for us to jump inside. Yeah. But one of the things we can do, like I mentioned with the scoop, is we can actually scoop the patient out with the spinal cord. Yeah. But it's always a challenge to manage, especially if there's no other like lifeguard or anyone skilled to enter the water with you. Yeah, that would be a bit hard. The other challenge for this case was that the drying of the patient, trying to find a dry spot to carry the patient to while managing spinal precaution, that was a bit tricky. It was almost the whole area was wet, and because we're trying to make sure that there's no further injury to him, it's a lot to manage and to be careful about. Okay, the second case study was a 72-year-old female, also in the condo pool. The daughter actually was with her. So at a certain point, the daughter wanted to go to the jacuzzi. She told her mom, don't swim alone. So she went to the jacuzzi. Her mom, last seen, was sitting at the edge of the pool. And just, I think about 5-10 minutes later, she turned her head and the mom was really floating, face down. So when EMS arrived, the patient was at the side of the pool with the legs halfway in the pool. So they managed to pull her out. Singapore Police Force was on scene, I think, because the patient actually called 999 instead of 995. Yeah. So SPF was doing CPR. The daughter was also doing mouth-to-mouth ventilation. And because the patient, I think, aspirated a lot of water, there was actually a lot of vomiters on scene. So 3 cycles of compression was done before EMS arrived. And then when they took over, there was no pulse, there was no breathing. This paramedic inserted the OPA first. So she ensured a patent airway. Insertion of OPA takes like 3 seconds. So it's very fast. So this paramedic just made sure to ensure the airway was good first, and then moved her out. So the first time they tried to insert the LMA, the one that goes deeper, it was a bit hard because of the vomiters, so they had to actually clear that out first, and when they tried it again, it was successful. They managed to get an IV line in, they managed to give 3 adrenalines in total, But unfortunately for this case, 6 cycles of analysis was done, and all of it was asystole, which is a flat line. So they expedited her to the nearest hospital, same thing, stand by the hospital to receive the patient. So some challenges for this case, because the patient was a female, she's wearing a one-piece swimming costume, and it actually took the paramedics quite a while to cut through the swimming costume, dry the patient, place the AED pads. So compression was interrupted here and there. We ideally want to limit that as much as we can, right? But because you have to get the pads on, you have to keep her dry. These are things that will start to come in. Yeah, and then because she was wearing one piece, the whole body was really very wet. I think total they took about 10 minutes to eventually dry, get pads on, and have like proper compressions without interruptions anymore. The good thing for them was they actually had a dry spot some 20 meters behind. Yeah, so they did manage to bring the patient to a dry spot fast enough. Okay, so what can we do then before EMS arrival? Because when we come, there are a lot of things that are out of our control, and sometimes there are first responders on scene, and these definitely will, sorry, not first responders, sometimes there are bystanders on scene, and these will definitely help to increase the patient's chances of survival. So if you're able, if you're skilled, you can remove the patient from the water. You definitely want to call 995, don't forget that. If you can find an AED in the area, you can do so as well. If the patient is conscious and you can try to help them vomit. If the patient is unconscious, you can actually leave them in a recovery position, which is basically lying on the side. So you want to make sure that they're not face up like this way. Whatever will flow up, can flow up, will flow up. And if you see any foreign body, you can try to even pull it out as well. If you find that the patient has no pulse, you can actually start compressions as well. And if you're brave enough, you can do mouth-to-mouth ventilations. You can even just do, if you don't feel you can do any of these things, you can just even do the simple act of finding a dry towel, because these things will go a long way eventually. Like how the previous case, the paramedics had to spend about 10 minutes or so trying to dry the patient. Yeah, these can all be very quickly resolved. You can find a dry towel, you can move the patient to a dry area as well. Cover the patient with extra towels, so you want to keep them warm. And if there's any oxygen available, you can actually give. So I know some cases where the lifeguards actually already started giving oxygen before the EMS arrived, and this helped the patient a lot. Because by the time they arrived, by the time EMS arrived, oxygen levels were already way up. Okay, and just to end off, some simple tips for ensuring safety during water activities. So, if you're unwell, if you're currently on medication, if you have any known history, medical history, if you're already on MC or light duty, or any kind of letter by a specialist, don't swim. Just avoid the water activity. And if you, for some reason, cannot avoid the water activity, then don't go alone. But always make sure you have someone watching you, always make sure you have someone with you. Unfortunately, a lot of the cases that we've received, a lot of the patients were alone, or even just left for a few seconds or minutes. Whatever you're going to do, whether it's diving, whichever, swimming, just ensure your skill level actually matches your water activity that you're going to participate in. And even if it does, don't ever think that there's no chance for danger, risk management, right? So, and also ensure whatever gear you're going to wear, whatever safety gear you're going to put on, ensure they're in good condition, perform your safety checks, don't take small things for granted, because at the end of the day, safety first is always the most important. Yeah, okay, I'm done. Thank you very much.
Thank you so much, Ms. Wong, for the insightful session. Very, very important.